Hello everyone. Now we are going to deal with the vergence system. The vergence eye movement shift the gaze near and far such that the image of the target is maintained simultaneously on both the fovea. Unlike other eye movement systems, the vergence system or the vergence movements are disjunctive. That means the eyes moves in the opposite direction. To move from a far to near target, the eyes converge. That is, they rotate towards the nose. To aim at a target farther away, the eyes diverge. That is, rotate towards the temples. If you notice, during deep sleep or deep anesthesia or coma, the eyes diverge beyond parallel, indicating that the eye alignment is normally actively maintained by the brain. They are not parallel, they are little bit diverged. So to maintain them parallelly, to maintain the eyes parallel, the brain will act. Why? Because the orbits in which these eyeballs are located are divergent. So that's why normally if you find in a patient in a coma or under deep anesthesia, you can find that the eyeballs are little bit divergent. This vergence system is relatively new system in the process of evolution. Just like that of a new software, we'll be encountering many bugs. This vergence system is the last eye movement system to reach the full development in children. It is often the first system to be affected by fatigue, alcohol, and drugs. The defective vergence is the common cause for strabismus and diplopia. The vergence is a very slow eye movement. It usually lasts for 1 second or longer. Why? Because it is driven by the visual feedback, which normally takes around 80 milliseconds. The other reasons why this vergence is slow is the vergence is accompanied with the change of shape of the lens, what we call accommodation, and also pupillar constriction. So the accommodation and pupil constriction will take some time. So there may be simply no advantage for the vergence to take place quickly and then to wait for the lens for the accommodation and for the pupils to constrict. So that's why the vergence eye movements are little bit slower. So the triad of the vergence, accommodation and pupil constriction is called as near triad. So for stimulating vergence, two important stimuli are there. The first one is the retinal image blur and the second one is the retinal disparity. Retinal image blur means if the retinal image of an object is blurred, the target is either too far or too near. So to visualize that perfectly, accommodation takes place. There will be change in accommodation which is accompanied by the change in the pupillary size as well as change in the vergence. So retinal image blur is one of the stimuli for vergence. In the same way, similarly, if a single object casts its image on non-corresponding points on the two retinas, Divergence eye movements are elicited to realign the lines of sight to achieve single binocular vision. The other eye movements can be directed along any meridian, like horizontal, vertical, and torsional. But divergence is most robust along the horizontal meridian because the eyes are separated horizontally in the head. And so horizontal divergence is functionally most useful. Although sometimes you can see vertical and torsional divergence, by vertical and torsional disparities, their amplitudes are much smaller than the horizontal divergence. And if you notice, this is why a vertical or torsional strabismus is very, very poorly tolerated. Because the vertical divergence and the torsional divergence are not fully developed. So the neural pathways are also not that clear, but we are going to give the most putative neural pathway for the divergence. The malfunction of divergence accounts for a number of disorders. The convergence insufficiency causes diplopia at near distances. That is, the convergence insufficiency causes diplopia at near distances, which is most commonly seen in young adults who complains of eye strain, headache, that is the periauricular headache, the blurred vision after brief periods of reading. Convergent insufficiency is also found in patients with Parkinson's disease or progressive supranuclear palsy. So, abnormal synchytic relationship between the divergence and accommodation is a common cause of childhood strabismus. So, if a child is having strabismus during the childhood, so there might be some accommodative defect. And there must be some dyskinetic or abnormal synchytic relationship between divergence and accommodation. Now let's quickly move on to the characteristic features of the divergence. Firstly, the velocity. Divergence movement shows two types of responses, a fast divergence movement and a slow divergence movement. Fast divergence is a response to a large and abrupt change in disparity. For example, when one person abruptly changes focus from near to far, there will be very fast divergence. Slow divergence is seen as a response to small and slow change in disparity. For example, tracking a target that moves slowly in depth. The divergence follows main sequence. So what is main sequence? The peak velocity of the divergence increases with its amplitude. The peak velocity increases with its amplitude. So this is also seen in saccades. Next is convergence is much speedier than the divergence. Coming on to the second characteristic feature, the latency. The latency of the divergence movement is about 200 milliseconds for retinal blur stimulus, and the latency is around 80 to 160 milliseconds for retinal disparity stimulus. Coming on to the waveform pattern, in convergence, we will be seeing the increasing velocity waveform pattern, and in divergence, we will be seeing the decreasing velocity waveform pattern. This divergence system frequently interact with saccades. most Virgin's eye movements are accompanied by disconjugate saccades, and these saccades speed up the Virgins. So during horizontal saccades, the eyes transiently diverge and then converge, aligning around 50 to 60 milliseconds after the completion of the saccade. So initially they transiently diverge and converge, and after that align after the completion of the saccade. So during the upward saccades, there is often an initial divergence, and during the downward saccades, there is an initial convergence. So now let's move on to the neural substance of the Virgin's pathway. Now this is the simplified putative pathway, and in the next slide we will be seeing in detail. So the striate cortex and the parietal cortex signals it to the frontal eye fields. From the frontal eye field, the signal goes to the nucleus reticularis tegmentae pontis, NRTP. We have seen this NRTP in vertical pursuit as well. From the NRTP, the signal goes to the cerebellar cortex, particularly the vermis, the fastigial nucleus, and the nucleus enteropositus, and the flocculus of the cerebellum. From there, the signal directly reaches to the supraoculomotor area in the midbrain. This supraoculomotor area lies within the mesencephalic reticular formation, around 1 to 2 millimeters dorsal to the oculomotor nucleus. From there, the signal goes to the oculomotor nucleus. And if you notice this pathway, except the nucleus reticularis tegmentis pontis, this entire pathway is bypassing the brainstem. So in brainstem lesions, you can find the loss of saccades, the loss of pursuit, the loss of VOR, that is the vestibulocular reflex. But usually the vagency is not gone, because from the cerebellum, the tuned signal directly reaches the supraoculomotor area. This is one crucial important point to be noted. And let's go little deep into the neural substance pathway. Like from the frontal eye fields, from the parietal eye fields, and particularly from the striate cortex. In the striate cortex, there will be 3 types of neurons. That is, tuned zero type of neurons for fine stereopsis, tuned far neurons for coarse stereopsis, and tuned near neurons for coarse stereopsis. These 3 types of neurons are being stimulated in the striate cortex, and from there the signal is being transmitted to the parietal lobe, that is the parietal eye fields, particularly the lip, lateral intraparietal area, and also the middle temporal and the medial superior temporal areas. From there, the signal directly reaches the supraoculomotor area. But a refined signal, that is from the frontal eye fields, goes to the nucleus reticularis tegmentae pontis, where you will find the neurons for convergence and divergence lie close to the saccadic area of the NRTP. From NRTP, the signal or the fibers go to the cerebellum, particularly the dorsal vermis. The dorsal vermis discharge during the far response. And the fibers also goes to the fastigial nucleus which discharge during near response. The fibers also go to the cerebellar nuclei. You all know there are 4 different types of nuclei in deep cerebellar nuclei. One is the dentate nucleus, emboliform nuclei, and fastigial nuclei and globose nuclei. The emboliform and globose nuclei together are called as the nucleus interpositus. You can simply remember DEFG: dentate, emboliform, fastigial, and globose nucleus. 4 types of nucleus. E and G, emboliform and globose, are together called as nucleus interpositus. So the Virgin signal reaches the nucleus interpositus, which discharge during far response. So the vermis and the nucleus interpositus discharge during far response, whereas the fastigial nucleus discharge during near response. And few fibers also reach to flocculus, which discharge in relation to the Virgin's angle. And from there, the signal is being transmitted to the supraoculomotor area in the mesencephalic reticular formation. In the supraoculomotor area, we will be finding 3 types of neurons. One is for the Virgin's burst cells, the other is the Virgin's tonic cells, third types of cells are the Virgin's burst tonic cells. So one is for the birth, they are the burst cells, the other are the tone maintenance cells, and the third one are the combined thing. From supraoculomotor area, the fibers reach the oculomotor nucleus, particularly the subgroup C of the medial rectus muscles, whereby stimulating both the medial recti at a time, thereby converging. From the supraoculomotor area, the fibers also reach the abducent nuclei on both sides for divergence. Next, clinical points. As we have discussed earlier, the nucleus reticularis tegmentum ponti discharge during vergence. The vermis and the nucleus interpositus discharge during far response. The fastigial nucleus discharge during near response. The flocculus discharge in relation to the vergence angle. All these 4 points we have discussed earlier in the pathway while describing the pathway. So now, with these clinical points, you can add the clinical scenarios where the lesions of NRTP can cause impaired holding of the vergence angle. So the lesions of the vermis can cause esodiviation, that is excessive convergence. Why? Because if there is a lesion on the vermis, the Purkinje cells inhibitory influence on the fastigial nucleus will be gone. And what does the fastigial nucleus? Do the fibers for the vergence system in the fastigial nucleus, they respond for the near response. That means they stimulate convergence, right? So that's why when there is a lesion in the vermis, the Purkinje cells lose control, inhibitory control over the fastigial nucleus. Thereby the fastigial nucleus become overactive for the vergence, thereby causing the two eyes to converge. Excess convergence will be there, so you will find isodeviation. Whereas in the lesions of the fastigial nucleus, the ulta happens. You will find the exodeviation. There will be excess divergence because the Purkinje cells which are in the dorsal vermis, which responds for the far response, which discharge during far response. For far response, you will need to have divergence. So excess divergence will be there in cases of the lesions of fastigial nucleus. So with this, we conclude this section. Thank you.